Morning, everybody. It's a real pleasure to be here and to be able to share some time with you, talking about something that I'm really passionate about, and that's quality of life in people with bipolar disorder. So let's set the scene a little bit. If you look at this slide, this is where I'm speaking from today. This is downtown, beautiful downtown Vancouver with the North Shore Mountains in the distance. This is the campus of the University of British Columbia. This is the hospital site just here where the Department of Psychiatry is, where we are today on a day that looks much like this. For those of you that are planning a trip perhaps to Vancouver at some point, we are quite well known for the fact that we have a beach down off the campus here. This is called Wreck Beach. This is rather infamous because it's it's the closest nudist beach to a downtown core anywhere in the world. So just to point out as a possible tourist spot for people in the future. Another tourist option at the moment would be our beautiful Cherry Blossom Festival, which is just starting this week. And these are some photos that have been taken and put on the annual 2013 Cherry Blossom Festival website in town. So let's start with a few disclosures from me. First of all, I very rarely, if ever, work in isolation, and the topic that I'm going to talk to you about today, quality of life, really is the subject or the result of a collaboration with a number of key people. First of all, Dr. Greg Murray from the University of Swinburne in Melbourne, Australia, is a long-standing colleague with me. We've been researching quality of life in bipolar disorders for about 10 years together now. Victoria Maxwell is a member of our team. She lives with bipolar disorder type 1. She's a mental health educator and actress. And she's going to be producing she has produced some role play videos with those of the team, which I'm going to refer you to later. Dr. Sagar Parikh from Toronto is the co-principal investigator on the grant that funded some of the research that I'm going to be telling you about today. This research has also been done within the context of a wider team, as mentioned by Ashley in the introduction. This is the collaborative research team to study psychosocial issues in bipolar disorder. And I just put this slide up as a reminder to myself that I wanted to let you know that the slides from today will be available on our SlideShare account. I'll give you details of that at the end of the talk, so don't feel that you have to take notes or anything throughout the presentation. I'll be providing it all to you. And these are my actual disclosures that I thought I should just put up briefly. Okay, so what are we going to be doing over the next 30 or 40 minutes today? At a broad level, I'd like to really introduce the concept of potential value of quality of life to you, with a particular focus on quality of measurement in clinical settings. I'm going to introduce a specific scale to measure quality of life in people with bipolar disorder that we've spent several years developing, and discuss its potential application in clinical practice. How are we going to get there specifically? I'll spend about 5 minutes or so unpacking this notion of what quality of life is. We'll look at what the rationale is for assessing quality of life in clinical practice. We'll spend about 5 minutes talking about the development process we went through to develop this QOL-BD scale. I'm going to look for a while at why and some common questions around applying the QOL-BD in clinical practice, and then look at some next steps and take some time for questions and answers. So this notion of quality of life, I think it's really worth spending a little bit of time unpacking this construct, because it's used and defined in a variety of ways. So let's spend a little bit of time doing that first of all. This is apologies for the screen that keeps popping up. This is the World Health Organization's definition of quality of life. You're going to be very familiar with it, but let's look at it in a bit of detail for a second. From the WHO perspective, they define quality of life as an individual's perceptions of their position in life in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards, and concerns. Now, that's a pretty wordy definition. It's something that I used for many years, actually, in publications without really having wrapped my head thoroughly around it. So I'm going to spend the next few slides just unpacking some of these elements a little bit. So first of all, this idea of quality of life measurements needing to occur from the perspective of the individual. That is, where possible, quality of life, from my perception, from my perspective, should be a subjective assessment process. Imagine, okay, let's try that. You can imagine some cases, I'm sure, where quality of life needs to occur in what we would call a proxy manner. So if we were wanting to assess quality of life, for example, in people with severe learning difficulties, with severe cognitive problems, or perhaps in younger children, it might be impossible for some people in certain situations to reliably and accurately report on their internal state of well-being. However, where possible, we think it should be a subjective process. I'm going to show you a couple of slides to unpack that a little bit. Now, this isn't data from our group. This is actually a quality of life measurement style that's taken from Kieran O'Boyle's group in Dublin and Ireland. And he's produced something called the SQL, the Schedule for Evaluation of Individual Quality of Life over Time. This is a measurement paradigm that is developed specifically to measure quality of life in a single given individual over time. So it's not a scale that's developed for looking at group level data. It's designed to evaluate subjective perceptions of quality of life in one person longitudinally. This is how it works. So the patient or person in question is given a disc. There are two sides to the disc, and when the disc is handed to them, they're equally distributed. The blue side of the disc that you can see represents the person's quality of life. The pink side of the disc represents the symptoms and the amount of interference their particular health condition is having on their quality of life. So you can imagine that both of these sides of the disc can be manipulated, the size of them can be changed. The larger this side of the disc, the pink side, the greater the interference or impact on the person's quality of life, and the more it reduces it. Data that you're going to see from the next few slides is taken from a single patient. It was from a study of end-stage oncology or cancer patients. These are people mostly with head and neck or throat cancer. They were at the end of their lives. They were typically intubated, in some pain, having some symptoms and some difficulties because of their physical health. What the researchers did was asked a number of people to assess the person's quality of life. So this is the nurse's perception of a particular patient who was a couple of weeks away from death. Her evaluation of the situation was that the person's symptoms from their cancer were really quite impairing the individual's quality of life. When they asked the person's physician, their MD, to go through the same exercise, his or her response was the same. Well, actually, it was even that the symptoms had even more of an impact, a negative impact on the individual's ability to have good quality of life. So I've asked you to hazard a guess what happened in the patient's experience. I wonder if you would have predicted this. When that patient, the same patient, was asked to make the same kind of response, they reported that actually their physical health condition and the symptoms associated with that were having very little relatively effect on the person, on their quality of life as they perceived it. What's really interesting to me as well is that when we start to look at these types of data, sometimes what we see is people even shifting emphasis on domains of quality of life as they get closer to death. And so it's the case for some people, for example, that they shift away importance from domains like pain, physical functioning, discomfort, and often shift towards other domains of quality of life, such as spirituality and faith, connections with family, meaning at the end of life. And so I think these slides just provide a useful framework for understanding for us in terms of how it is that objective ratings of quality of life aren't necessarily synonymous or the same as a person's subjective perspective. So to the next point of the WHO definition about culture and value systems in which the person lives. This is data that's taken from my own household. I'm a stepmother. I have two stepdaughters, Jessie and Jamie. This is Jessie here and Jamie back in 2007 when I first met them. And I thought that I would measure their quality of life over time in our house each year. And in 2007, when I asked them what determined whether they had good quality of life or not, they said the number of stuffies that they had. They were animal mads, so the number of stuffed animals at any given time. We breed dogs, and so the following year they reported that they were really quite happy because we had a litter of giant schnauzer puppies at the time, so their life quality was quite good then. Then they got into their preteen years, and in 2009, Jessie told me that her life would be much, much better if she had a pair of real Uggs, real expensive Australian Uggs. And then the following year, it was these, I always forget, these Hunter Wellies, also very expensive fashion accessory. And then things kind of deteriorated even further after that. Back in 2011, it was some kind of incredibly expensive handbag. I texted Jamie, actually, who's just gone into nursing at UBC last year, and she seems to have come through those kind of scary teenage wasteland years, and she responded that she was really focusing on her grades and becoming a good clinician, and that was her great determinant of quality of life this year, so I'm pleased to be able to report that data. Okay, so that's a kind of light way of looking at the person's system and context in which they're evaluating their quality of life, but it is of some importance. And then to this final point about relation to a person's goals, expectations, standards, and concerns. And let's take the opportunity now to bring this back around to bipolar disorder. I'm going to show you some data from an older study that we did when we first began researching quality of life in people with bipolar disorder specifically. I do a lot of qualitative or mixed methods research. This was a qualitative study. It was a fairly large sample for a study of this nature. It included about 35 people with bipolar disorder type 1 or type 2, 5 family members of people who were really quite severely affected by bipolar disorder, and a range of clinicians from around the world or researchers who are real field leaders in this area. And we sat down with these people and put them in interviews and focus groups and talked to them about their experiences of how bipolar disorder specifically impacts quality of life, and then analyzed that data thematically. And these are the headline results. These are the themes that came out, or the main components that people with bipolar disorder told us were important to have good quality of life. And many of these aren't going to be surprising to you. People told us that a good social support system was critical. They told us that in order to have good quality of life, one had to find a way to navigate around the substantial stigma, mental health and the mental illness stigma that surrounds bipolar disorder. This is an interesting theme. It's not that everybody in the sample described spirituality or faith or religion as being important, but enough of the sample, over a third of them, talked about it and talked about it frequently enough for us to know that for a good proportion of people with bipolar disorder at least, that feel that quality of life is dependent in part to having good spiritual life. Other common themes included a story around need for independence within the family context, independence within the healthcare system. And then a final theme that we identified was around sense of self, identity. Who am I in the context of bipolar disorder? Have I got beyond the point of where bipolar disorder overshadows me and got to the point where it's just one component of who I am? So the take-home messages from this introduction to quality of life, from my perspective, are that where possible, quality of life assessment needs to be done from the perspective of the individual with bipolar disorder. It's probably a process that depends on the context that that person is in. Quality of life itself is probably multidimensional. And I believe quite strongly actually, that there are probably some dimensions of quality of life that may be of particular importance. Let's turn to talk for a moment about why we should be assessing quality of life in clinical practice. I'm going to look at the research evidence in this area, focusing on 4 main points. And I'll go through each of these individually. First of all, I'm going to explain that I think that people attend to more than symptoms when they're evaluating how well we're doing in terms of our treatments for them. I'll show you a little bit of data that tells us that symptoms that have the same impact on, treatments that have the same impact on symptoms can actually have quite different impacts on quality of life. I'm going to make the argument that sometimes there's a mismatch or a disjunct between change in symptoms over time and change in quality of life over time. And then I'm going to make an argument for our ability to measure quality of life in bipolar disorder at this point of time in terms of the field of measurement. So first of all, let's have a look at this idea that people attend to more than symptoms when looking at how well they're responding to treatment. This is actually not bipolar disorder data. It's taken from a sample of people with unipolar depression from Mark Zimmerman's group. These were outpatients in treatment for their depression, and they were surveyed about the most important factors that determined remission. And these are what they told us, or told the researchers. It's interesting that only this part of the sample described that absence of depression was how they determined whether they were in remission or not. So far greater sample, we're talking about things like, do I have positive mental health? Do I have general well-being? Am I back to my normal sense of self? We also have some data on this in bipolar disorder, and so this is taken from a study that we completed a couple of years ago. It's an interesting piece of work where we were actually looking at people with bipolar disorder who are really managing well with their condition. We knew from our research that there are many people with bipolar disorder who do find ways to live well with successfully with the condition, have good health, and have good quality of life. And so we built a program of research to really focus on what they were doing to stay well and what self-management strategies they were using to get to that place. In this sample of nearly 40 people with bipolar disorder who were in a range of illness states, it was also a qualitative study, we asked them about what wellness and quality of life meant to them. And this is how the sample described wellness in the interviews, or quality of life. They described needing to feel balanced, maintain self-confidence, still have fun, have a healthy social life, meet their goals. And this is one that comes up quite frequently in bipolar disorder, maintaining their creativity. We know that many people with bipolar disorder are creative, and this is often an important aspect of wellness and quality of life for them. To the point that treatments, whether they're psychological or pharmacological, can have the same impact on symptoms, but sometimes different impacts on quality of life. This is some older data from a study that randomized people with bipolar disorder type 1 to olanzapine or another medication. And what the findings showed was that although remission rates were similar at the 6 and 12-week assessment points, one of the medication interventions showed superior health functioning that was measured by the SF-36 at both time points, and also a split or a difference in terms of work functioning at the 3-month assessment point. You may well have seen this data from Mauricio Toen's group before. The slide makes it around quite a bit, but I think it's quite powerful, and it's one of a number of studies now that have shown that there's often a mismatch between symptomatic outcome or syndromal outcome and change in quality of life or functioning over time. Typically, most frequently, we'll see quality of life and functional recovery lagging significantly behind the person's symptomatic recovery. If we're not including quality of life assessments, then we're really not able to tell if we've got people back to full restoration of well-being and quality of life, as well as recovery from that particular episode that they were experiencing. And to this point, that I think now, really for the first time in the bipolar disorders field, we are at a point in time where we think we can accurately measure quality of life in bipolar disorder. This is an old review paper that we published in 2005. I think it was one of the first systematic reviews of the quality of life literature in bipolar disorder. And at that point of time, we said in the review that there is at present no quality of life measure specifically designed for use in bipolar populations. An important step forward in this field of research would be made in the development of a disorder-specific scale. This is the scale of a publication in 2010 describing the scale that we produced to meet that gap. And this is a publication that just came out a couple of months ago, which kind of summarized where we were at, I think, in bipolar disorders in terms of this field of research and policy of life. To show you a graph from that publication, what this is showing you is number of publications in bipolar disorder that used a quality of life assessment over time. It's important to think about the numbers here because although we are seeing an exponential growth in this area, the sheer numbers of quality of life publications are still quite small. So over this time point, which was the last 20 years, we were seeing that about 140 publications have been done that have used quality of life measure. However, if we compare that to the number of publications over the same time period with a symptomatic measure, there's still quite a large group. We are seeing a real growth in interest in this field. Okay, so I'd like to spend a little bit of time walking you through how we developed the quality of life in bipolar disorder. It took us 5 years to develop this scale using a mixed methods program of research. And at the outset of that project or program of research, we really had in mind that we wanted our quality of life scale to do a number of things. We wanted it to work both in treatment settings and in naturalistic studies. We wanted it to work in routine clinical care, and we also wanted it to work as a self-management tool for people with bipolar disorder to help them manage their own chronic health condition. We needed it to work as well as possible across the spectrum of bipolar disorder diagnoses and mood states. Critically, we wanted to make sure that it was as easy to complete as possible, that it really presented minimum cognitive demand, while still, of course, maintaining strong psychometric properties. And the other really critical piece was we needed it to be sensitive to change. We were trying to design a scale that would be picked up by randomized clinical trials in the pharmaceutical industry and in psychosocial treatment trials. There were two main phases that we went through in terms of developing the scale. One, to generate a number of potential items or questions for the scale. And then the second main phase was to reduce these numbers, the number of items and questions, down as much as possible, to winnow them down to the least number of questions possible. We began with a range of qualitative interviews with people with bipolar disorder. We did a traditional literature review, and those two processes gave us 210 possible questions or items for the quality of life scale. We then went through a number of steps to reduce the number of questions down. Each of these steps involved people with bipolar disorder and experts in bipolar disorder care. So in the first step, we asked people with bipolar disorder to go through a really tedious, lengthy exercise where they went through those 210 questions and said of each question whether it was clear, whether it was any good, whether it had happened to them or occurred to them in the last 12 months, whether they deemed it to be important. That allowed us to cut down the number of possible questions in the scale. We went then through a large traditional psychometric evaluation, so over 200 people with bipolar disorder filled out the questionnaire once, as well as a bunch of other symptom scales. They then filled it out about a week later, again with a bunch of symptom scales, and this allowed us to get rid of some of the weaker items and reduce the scale down again to a shorter version. And then we went again back to people with bipolar disorder and back to our CREST-PD team members for a final exercise where we said of each of the questions in each of these domains of quality of life, which are the keepers, which are the very best ones in your expert opinion. And that allowed us to produce what we have in terms of the full item, the full version of the QoL-BD scale, which is 56 items. So this takes the average person with bipolar disorder about 4 or 5 minutes to complete. And you can see that it's really been designed for ease of answering. There are 4 items to each of the domains in here, but we don't have any subheadings because we found that would slow people down and increase the cognitive load attached to this questionnaire. And so we really made it, with lots of user engagement, as easy to complete as possible. These are the different domains that exist within the quality of life scale. There are 12 basic ones, and some of these are the same domains that you would see in the majority of other quality of life scales. Physical functioning, how's your leisure life, how's your social life. However, you'll also see that some of them are a bit more specific, perhaps, to bipolar disorder. And I'm going to show you these in a bit more detail. Things like sleep, spirituality, finances, independence, identity. And then there's two optional scales looking at work and education, depending on the person, whether they're in work and education or not. These are some examples of the actual questions in the sleep, self-esteem, and identity domains. The sleep one, we find that these are very powerful predictors of quality of life in bipolar disorder. In particular, the question, have you woken up feeling refreshed this morning? You don't need me to tell you that keeping a routine and sleep wake schedule is critical for many people with bipolar disorder to live well. In terms of self-esteem, I actually think this is kind of a stigma scale as well, feeling accepted by other people. Over the last 7 days, how worthwhile as other people have I felt? Have I been able to cope with stigma? And in terms of identity, have I had a strong sense of self, a stable sense of what I'm really like? So I'm hoping that gives you kind of a feel of what the core BD is like to complete. It's also a brief version. This is even more sensitive to change than the long version or the full version. This takes just a minute or so to complete. And this is the one that's been picked up by a number of large ongoing pharmaceutical and psychosocial treatment trials. Okay, so I think at this point of the presentation, I've put together a few questions or answers to questions that I commonly get asked about how do you use the core BD in clinical practice, and really these answers also apply to the idea of how would I use the core BD as a self-management tool. One by one. So we've already touched on this one. How long does it take to complete? A minute or so for the brief version, 5 minutes or so for the full version. Question of do I use the short or the full version? It really depends on why you want to use the quality of life assessment, whether it's for research, clinical purposes, self-management. Our suggestion is that in clinical settings, really the full version, the 56-item version, is going to give you more information and be more useful for you clinically. Specifically, there are individual domains and information there that might be of particular interest to particular types of clinicians. So, for example, occupational therapists might want to have a particular eye on the work domain, or the leisure domain, social workers, the social domain. However, for research settings and for clinical trials where really assessment times are of the essence, the brief version shows very, very strong psychometric properties. It's even more sensitive to change than the full version of the scale. And so that's an excellent one to choose in clinical trial environments. In what mood phases should I apply it? We're still collecting data on this. We've administered the scale in a number of studies, in a number of people in a variety of mood states. It works well in people across the range of severity of depression, so from mild depression through to very severe depression. It works well in periods of normal mood or euthymia. It works well in hypomania. We've had some people who have been in full-blown manic episodes complete the scale, and we haven't had a large population or a large data set to respond on that yet. There are a couple of studies ongoing now which are using it specifically in people who are in mixed states or manic states, so we'll have more data on this soon. It works better than you might think, however. Sometimes you need to support people when they're completing it, if they're getting a bit tangential, to help them keep focused. Sometimes it is impossible, I think, for some people in mania, when they're really quite deep in psychosis or really not in a place where they can reflect on how they are at that particular point in time, for them to really accurately respond to quality of life assessments. But it's yeah, it works surprisingly well, I think, in mania. We're looking forward to seeing some more data come out on that question. What else should I measure at the same time? Whether you're a person living with bipolar disorder, a family member supporting somebody to manage their condition, or a clinician, the answer to this is always going to be the same. One should never measure quality of life in the absence of a depression measure. And I would also argue that, depression measures should also really go hand in hand with a functioning or quality of a life assessment, because they give you really different kinds of information. But a brief depression scale administered at the same time as the quality of life scale will give you an idea of some of the overlap and variance between the two. Depression and quality of life outcomes are not the same thing. They're not synonymous. I think this is a kind of a myth that still prevails in some of the literature, and still when I give presentations, somebody will say to me, well, aren't you just measuring the same thing? If you restore depression, doesn't quality of life just also bounce back? If you looked at all of the studies that look at the degree of variance or shared variance between depression outcomes and quality of life outcomes, typically depression will account for about 30, maybe 40% of the variance in quality of life, but it isn't all of the picture. So critical, I would say, to measure both at the same time. What time frame should I assess quality of life over? In the bipolar disorders literature, people are picking up differences in treatment outcome as early as 2 or 3 weeks after baseline intervention. However, generally, really, we should be looking at quality of life longitudinally over longer periods of time. If you think about some of the domains in question that we're talking about, like social support, restoring your marriage, fixing your finances after a manic episode, these are going to be things that take some time to restore. And how do I detect meaningful clinical change? And so this is something that we're working towards. It's something known as minimally clinically important difference, or MCID. At a point in time when we have more trial data on the QoL-BD, we'll be able to say that you're looking at a certain percentage improvement in quality of life scores over time to know that somebody has responded in a meaningful way in terms of their quality of life. It will probably be something in the 10 to 15% range. However, we don't have that data yet. I think what we can say at this point in time is that it's probably most useful to look at the person's, the individual's own idiosyncratic trajectory of change in quality of life over time. Where did they start, for example, is a really important question. An alternative method that some people use in the quality of life field is saying that, well, we need to get people back up to normal or general population levels. So you might want to say that if the general population scores 70% of 100% on average on a quality of life scale, we want people with bipolar disorder to be back at that 70% range. That's very laudable. A lot of people are using that approach in research studies. However, I would say that that's a pretty big ask for a lot of people if they're starting at 20 or 30% of total possible score on a quality of life scale. So really looking at where the person begins, I think, is an important part of the picture. PressBD is a knowledge translation network funded by the Canadian government, and our job is to make sure that resources for bipolar disorder and bipolar disorder research results, of which there are many, get into the hands of people who need them. So that is people living with bipolar disorder, their family members, people who care for them, and clinicians or healthcare providers. And so what we've been very busy with over the last 2 or 3 years is really producing a very wide suite of resources that can help you with self-management, supporting self-management in bipolar disorder, will help you with quality of life assessment. So this shows you a screenshot of the quality of life section of our website. And there you'll be able to find things like translated versions of the scale. It's not copyrighted, it's free and available for use in research, clinical care, or for personal use. The short and the long forms or full versions are available for download there. There are a number of additional resources like copies of all our scientific papers that we've produced. There are book chapters that are written specifically for clinicians, and also a number of videos. We've been producing a lot of YouTube videos recently. And this is the range of YouTube videos that are available in the quality of life area right now. I think at this point what we're going to do is I'm going to try and move over just to the website to show you how this looks on the website itself, well actually on our branded YouTube channel. So what you can see here, this is Dr. Greg Murray. Um, Unfortunately, we don't have the software capability to play these videos for you now. There was too much of a lag on the system to do it effectively. But I encourage you to have a look at these two videos if you're interested in learning more about how quality of life assessments bipolar disorder could be incorporated into routine clinical settings and treatment planning over time. So what we have is two vignettes that we just produced recently, where Greg, who's a registered psychologist, works with Victoria. So Victoria is playing a person with bipolar disorder in both of these vignettes, but she is also in real life a person who lives with bipolar disorder. I think it brings a sense of authenticity to the role play as a result of that. So there are two videos for you to view there. They're about 10 minutes long each. And then a variety of other videos that describe just different aspects of our quality of life assessments, program of research, and aspects of breastfeeding. Okay, and so I'm almost done with my formal part of the presentation, but I just wanted to end very briefly telling you about the next steps for this program of research. We were delighted to hear just a few weeks ago that we've secured more funding from the Canadian Institutes of Health Research, that's the Canadian Health Funding Agency. And specifically, we secured something called a patient-centered e-health grant. And what this is going to allow us to do is develop a web-based method for measuring quality of life over time in bipolar disorder using the QOL-BD scale. So it will be developed in both French, Canadian, and English. As you can imagine, it will be a secure portal that people can go to if they live with bipolar disorder to complete the QOL-BD online. They'll also be able to go back and complete it longitudinally over time, and they'll receive graphical and visual feedback that they can use for their own self-management purposes, or print out or take and share with their clinician to look at kind of treatment planning over time. What I think is really neat about this project isn't just the fact that we're going to be ramping up the software development around the QOL-BD, but that won't be the end of it. So if you imagine, for example, somebody with bipolar disorder does the questionnaire and gets personalized feedback about their quality of life, and the feedback says something like, okay, well, it looks like you're doing pretty well in the social domain and your leisure activities are fine, but it looks like you're having a little bit of difficulty in sleep and physical functioning. What would then happen is that the software will dovetail and lead people to tailored evidence-based resources for those specific domains of quality of life that are in deficit. So, for example, it would take them to the Wellness Resource Center of our website and say, we've been doing other research to really identify what are the most effective management strategies for sleep in bipolar disorder, and it would walk the person through tailored bipolar disorder sleep intervention tools, or tools to help them improve exercise and physical function. We collaborate heavily in everything we do, so if you're interested in this project and would like to feed into it, we'll be consulting heavily over the next year on how this tool should look, how we can design it optimally for healthcare providers and people with bipolar disorder alike. So I encourage you to get involved if this is of interest to you. And if you do want to get involved or hear more about CREST-BD more broadly, these are some ways to do that. If you go to the Get Involved section of our website, you can sign up for our newsletter, which comes out once a month. Here's my email address down here. We have busy and active social media outputs, including Twitter, Facebook, and everything we do pretty much as a team comes out on SlideShare, and so all of our presentations are done on different topics are shared through that format as well. And I think at this point we're ready for the question and answer session. And we also have a couple of little closing poll questions as well to complete the presentation for today.
Thank you so much. I will open it up and complete the 3 polls, and you guys can answer those as you start asking us questions. So here is the first poll. Thank you. And here is the next one. And our final one, and then we will get to the questions. Thank you. So our first question, Dr. Michalak.
I'm here.
Okay. Our first question is, excellent presentation. How do you factor in the assessment when there are a fair amount of medications assisting in the moods and quality of life in the long term? As you know, medications change regularly, and so would the assessment.
So I think the question is about changes in medications over time and how does that play into the assessment of quality of life over time?
Correct.
Really, yeah, thanks. Quality of life is a tricky construct to capture. This is partly why I think it's taken us 5 or 6 years to develop a scale to really accurately measure quality of life in bipolar disorder. And you know, the field had some way to go in terms of measurement precision, and it's particularly because of these kinds of complexities as raised in this question. If people with bipolar disorder do go through multiple medication trials, and it's difficult sometimes to tease out the specific impacts of those, the only way, in my perspective, to really start to get a handle from a research perspective on some of this is to do well-designed longitudinal research over time in people with bipolar disorder in fairly large samples. And so we have a couple of big projects underway right now where we're measuring quality of life daily, in fact, multiple times a day. And also things like medication adherence, whether the person taking medications at all, whether they were getting psychosocial treatments, whether they're having life events, whether they're using drugs and alcohol on those days, and the range, the myriad of things that will play into outcomes in bipolar disorder, in addition to their medications. Only with that kind of research and the sample sizes that would allow you to use quite complex modeling approaches to unpack all that complexity are going to allow us to get to a point in bipolar disorders research where we can really start to tease some of this apart. We're not there yet in terms of quality of life research in BD. We really need to see things like structural equation modeling and big samples of lots of people with bipolar disorder over time. But we're on our way. There are a number of studies that have been funded, and a number of studies that I know are actively collecting these kinds of outcomes over time and are going to allow us to address some of these questions more thoroughly. Good question. Thank you.
Thank you. Our next question is, have you considered making an app for bipolar patients to do quality of life assessments?
Okay, good question. So the e-health grant that I mentioned is going to provide a web-based method for completing the core BD, and it will be cell phone or mobile phone enabled or designed. So it will be able to be used on a smartphone, for example, but we haven't gone as far at this point of thinking about app development. It could be a step down the line. There are a lot of apps available currently in bipolar disorder, and I think we would see that maybe as a final stage of the process of research. We want to make sure that we have the science 100% right before we get to the stage of developing apps.
Thank you. Our next question is, I'm curious if the quality of life bipolar disorder assessment addresses side effects of medications. My personal example is trying to deal with tremors while working as a massage therapist.
Mm. The question actually is, does it assess side effects of medications?
Uh-huh.
Yeah, thanks. There isn't a question in there. No, there was in one of the original longer versions of the scale, but it wasn't a question that made it through. We think that it's really important in clinical settings to think about the interplay between potential side effects of medications and quality of life. And your example, given by the person who asked the question there, is just a beautiful example of that, because for somebody whose entire profession, livelihood, identity, sense of self is dependent on being able to do their job and not have their hands shake too much during that process. And that person is likely, I would hazard a guess, to be weighting those side effects pretty heavily. And really, they would be carrying quite a toll for that individual. Imagine a musician who's in a similar situation and then has hand shakiness or tremor and isn't able to play their instrument. Without assessing quality of life and the interplay between the particular medications and side effects profiles associated with them, we're going to be missing part of that picture. The reason there isn't a side effect question in the core BD scale is because there are lots of good scales to measure side effects already. Our idea is that you should just do both at the same time. So in a comprehensive assessment of somebody who you're starting to work with bipolar disorder, you would probably want to be looking at symptoms, quality of life, what they're doing for work, and side effects as well, and what they're experiencing. So that would be part of the holistic assessment, I would suggest.
How can we find out the quality of life scale after the assessment is completed? Can
you repeat the question for me?
How can we find, I'm not sure if this is correct. Michael, do you mind clarifying your question? I'll go to the next one right now. Have you made a depression assessment as well?
Can you say that again for me, Ashley?
Have you made a depression assessment as well?
If the question is, have we made a quality of life scale for depression?
Correct.
No, we haven't. Do you think that's the question?
Yes.
No, because there are lots of other great people doing that work and have done that already. We focus specifically on bipolar disorder. But, it leads to an interesting point, which is if you wanted to compare people with different kinds of diagnoses using the same scale, what would you use? The core BD is a condition-specific scale. It's designed specifically for people on the bipolar spectrum. So I don't know if it would work in people with unipolar depression or not. We haven't tested that out yet. I can't imagine it would work as well as it would work in bipolar disorder. But there are other really good scales that are designed to measure specifically quality of life and depression. One that we really like is the Quality of Life and Enjoyment Satisfaction Questionnaire, developed by Jean Endicott. That's been used in bipolar disorder too, and also works very well in depression. That would be a really good one to start with if you were looking around. But there are a number available.
Thank you. So Michael just clarified. After you add up the numbers from the assessment, is there a scale that tells you what your quality of life is from the final number?
Ah, right. Okay. Thanks for clarifying that. If you go to our website, there is a FAQ, a frequently asked questions section of the website, and there are a couple of bits in there on scoring the qual BD and interpreting the results. And it's a pretty simple process. You can either do it at a domain level, and it gives you some numbers around that. So, if you're scoring mostly fours, for example, then that would suggest to you that your well-being in that domain is mostly on the very good end. And so there is a way of kind of interpreting it numerically. However, we are not big fans of giving sheer numbers to quality of life in bipolar disorder. So I don't think I'm ever going to publish a paper that says if you have 70%, then you have, optimal or perfect quality of life in bipolar disorder. I think it's sometimes a dangerous thing um, to apply hard numbers to something as subjective and personal as quality of life in that way. So I think, like the point I was making before about where does the person start, if, in terms of their quality of life, if they were very, very impaired before you started treatment and you saw maybe a 20% improvement in scores, that's a pretty significant increase. But that person would still be way below the 70% ideal score. So I'm a little bit gun shy of applying hard and fast numbers very bluntly to quality of life interpretation.
Thank you. And that is all the time we have for questions. We really appreciate all the work you did in putting this together. It was excellent, and letting us know about this assessment that is available. I just would like to remind everyone that all our webinars and lectures are free. So if you would like for us to continue these, we do ask for a small donation. And you can do that on our website at internationalbipolarfoundation.org. So thank you again, everyone, for joining us today.
Thank you, Ashley.